Welcome to our lecture on cardiac neoplasms. Let's get started. In this lecture, we will discuss the atrial myxoma. For atrial myxoma, we will discuss the definition, clinical presentation, diagnosis, differential diagnosis, and the management. Myxoma is the most common primary cardiac tumor in adults. It's a gelatinous tumor found most commonly in the left atrium. That's why it's also called an atrial myxoma. Most clinical features of an atrial myxoma are caused by the ball valve obstruction in the mitral valve annulus. When the myxoma obstructs the mitral valve annulus, it decreases the venous return into the left ventricle. Therefore, the left ventricular stroke volume and cardiac output will also be decreased. Decreased cardiac output results in multiple episodes of syncope, exercise intolerance, and fatigue. On the other hand, a space-occupying myxoma in the left atrium causes backflow of blood into the pulmonary vasculature. This may result in pulmonary edema and shortness of breath. Additionally, small parts of the myxoma may dislodge and embolize into the systemic circulation. If the dislodged part of the myxoma occludes the cerebral arteries, then the patient will develop stroke with possible dysarthria, dysphagia, vision abnormalities, or weakness. If the parts of the myxoma embolize to the renal artery, this may cause a pre-renal acute kidney injury, evidenced by increased blood urea nitrogen, creatinine, and BUN creatinine ratio. The urine output will be decreased as well. Finally, if parts of the myxoma embolize to the superior mesenteric artery, the patient may develop acute mesenteric ischemia with severe abdominal pain, hematochezia, and lactic acidosis. The other non-specific clinical features of the atrial myxoma are caused by interleukin-6 production by the tumor. Interleukin-6 is a pro-inflammatory cytokine responsible for acute phase reactant production and the constitutional symptoms. These constitutional symptoms involve fever, weight loss, and night sweats. Let's talk about the diagnosis now. First, heart auscultation will reveal an early diastolic tumor plop sound right after the mitral valve opening. This sound is caused by the atrial myxoma obstructing the mitral valve annulus in early diastole. Echocardiography usually reveals a hyperechoic pedunculated mass in the left atrium. Finally, a biopsy of the mass will show the myxoma cells immersed in glycosaminoglycan stroma. Here is an echocardiography image of a left atrial myxoma. Please note this hyperechoic mass almost completely occupying the left atrial lumen. Here one can see what the atrial myxoma looks like under light microscopy. One can appreciate these myxoma cells immersed in the glycosaminoglycan stroma. So let's read an example. A 45-year-old man presents with 5 episodes of syncope over the last 4 months. He also complains of shortness of breath, fatigue, and exercise intolerance. Cardiac auscultation reveals an early diastolic plop sound. The echocardiography shows a hyperechoic pedunculated mass in the left atrium. What will most likely be seen in the biopsy of this patient's mass? So pause the video and take a moment to consider this question. This patient presents with 5 episodes of syncope over the last 4 months. Cardiac auscultation reveals an early diastolic plop sound, and echocardiography shows a hyperechoic pedunculated mass in the left atrium. All these findings are consistent with the diagnosis of the left atrial myxoma. The biopsy of the atrial myxoma typically shows the myxoma cells in glycosaminoglycan stroma. Let's move on to the differential diagnosis of atrial myxoma. Here is the table listing the key features of the atrial myxoma and the other cardiac neoplasms. As we already mentioned, cardiac myxoma is the most common primary cardiac tumor in adults. Decreased cardiac output due to mitral valve annulus obstruction causes multiple syncopal episodes and exercise intolerance. Fever, night sweats, and weight loss are due to increased interleukin-6 production. Cardiac auscultation reveals the early diastolic tumor plop sound. Echocardiography, on the other hand, shows a hyperechoic pedunculated mass in the left atrium. Metastatic disease is the most common overall cause of cardiac tumor in adults. Cardiac metastases commonly arise from breast cancer, lung cancer, and melanoma. The patient will exhibit the characteristic signs and symptoms of the primary cancer. This may be a breast lump in the case of a breast cancer, cough, or hemoptysis, in case of lung cancer and skin lesions in melanoma. Similar to atrial myxoma, the patients with cardiac metastasis may also present with fever, night sweats, and weight loss. Echocardiography will show multiple masses in the myocardium. In contrast, atrial myxoma is usually a singular lesion within the atrium. Kaposi sarcoma can also account for a cardiac tumor. It is a malignant vascular tumor caused by human herpesvirus 8. Kaposi sarcoma is common in immunocompromised patients such as HIV positive or post-transplant patients. It will be characterized by vascular tumors in other locations like skin, GI tract, and the lungs. Echocardiography will reveal multiple vascular lesions in the myocardium. Finally, cardiac rhabdomyoma is the most common primary cardiac tumor in children. It's common in patients with tuberous sclerosis. Biopsy of the cardiac rhabdomyoma typically shows hamartomatous growth. It's more commonly found in ventricles than atria. Let's talk about the management now. The mainstay of treatment of atrial myxoma is surgical excision. However, if the patient has the recurrent atrial myxoma, then a heart transplantation can be performed. So let's pause the video and take a few minutes to consider this question. A 50-year-old woman presents to the emergency department with weakness, difficulty speaking, and difficulty swallowing for the last 3 hours. She has had 6 episodes of syncope over the last 3 months. She had an acute mesenteric ischemia 5 months ago. Her family history is significant for breast cancer in her mother and melanoma in her father. She has been smoking 3 packs of cigarettes per day for the last 30 years. Her vital signs include a temperature of 37 degrees Celsius, a blood pressure of 145/90, a heart rate of 84 beats per minute, and a respiratory rate of 15 breaths per minute. The physical exam reveals weakness in the left arm and left lower face. Cardiac auscultation shows the plop sound shortly after S2. Echocardiography reveals a single mass in the left atrium. Non-contrast head CT scan is performed. So which of the following is the best next step in the management of this patient? A. Surgical excision, B. Chest X-ray, C. Mammography, or D. Skin evaluation. So this patient with weakness, dysarthria, and dysphagia likely had a stroke. She has had 6 episodes of syncope over the last 3 months. She also had an acute mesenteric ischemia 5 months ago. The cardiac auscultation shows the plop sound shortly after S2. Echocardiography reveals a single mass in the left atrium. These findings are consistent with the diagnosis of an atrial myxoma. Embolization of the parts of the atrial myxoma account for her current stroke and previous mesenteric ischemia. So the next best step in the management of the patient with atrial myxoma is the surgical excision of the tumor. Therefore, the correct answer is option A. Here is the slide reminding us of the management of the atrial myxoma. So let's discuss why the other options are incorrect. Option B, chest X-ray, is incorrect because it cannot confirm the atrial myxoma. Additionally, although this patient has an extensive smoking history predisposing her to lung cancer, the metastatic lung malignancy cannot explain the single mass in the left atrium. Option C, mammography, is incorrect because it cannot confirm the atrial myxoma. Furthermore, although this patient has the positive family history of breast cancer, metastatic breast cancer would present with multiple rather than single cardiac lesions. Finally, option D, skin evaluation, is incorrect because it cannot confirm the atrial myxoma either. Although this patient has a positive family history of melanoma, the metastatic melanoma would present with multiple rather than single cardiac lesions. And that concludes our lecture on cardiac neoplasms.